We'll move to the next speaker, Dr. Nabil. He'll be talking on robotic kinematic alignment.
So, I've been doing kinematic alignment in various measurements. I started 5 years ago doing restricted kinematic alignment. First, I didn't move beyond 3 degrees of varus. Afterwards, I moved to 5 degrees of varus, and now I have no limits. But in 99.9% of cases, you don't go beyond the 5 degrees of varus. It's very rare to go beyond that. The kinematic alignment is something that it's not new. It's a reliable, safe, and well-established procedure. We have Professor Howell who started it in California. By 2012, he has done over 2,800 cases with good results, with good survivorship. We now have above 15 years of follow-up. Dr. Vendetti in Montreal, by the year of 16, he did over 1,000 cases. Dr. Vendetti does restricted alignment. What does it mean, restricted kinematic alignment? Restricted kinematic is he doesn't go beyond 5 degrees of valgus in the femur. He doesn't go beyond 5 degrees of varus in the tibia. And overall HKA, it's plus minus 5 also. But having said that, I will return to what I said before. 99% won't go beyond these measurements. We have also enough papers to support kinematic alignment. So even if you take retrospective studies, so they show either equal patient satisfaction and results, or better in the kinematic alignment. Same in RCTs. It's either better in kinematic alignment or as good as. You don't see any papers, studies that shows that kinematic alignment is better than, that mechanical alignment is better than kinematic alignment in the patient satisfaction. The aim of the kinematic alignment is very simple. Restore the pre-arthritic situation in the knee. And we try to put the 3 axes of the knee, the transverse axis where the femur and the tibia flex and extend together, the transverse axis where the patella rotates over the femur, and here you can see the yellow axis where the tibia rotates over the femur, longitudinal axis. So these are the axes that we try to restore while doing the kinematic alignment. And here where the vellus, so I do it still today manually with traditional jigs and also with robotics. I used to do it also with navigation, with the BrainLab navigation system. So here we see a planning of the after registration. Main issue is to restore the pre-arthritic situation. So we have a varus knee here, for example, with medial wear. So it doesn't matter if it's a varus or valgus, you look for the wear. So if the wear is medial, and we know it's about 2 millimeters of thickness of the wear, these are all measures that we take from Howell's papers. So we cut 7 millimeters from the medial side and 9 millimeters on the lateral side, because that's the thickness of the attune in the distal part of the knee. And on the back, it's about 8.5 millimeters and there's no wear on the posterior condyle. So if there's a wear, we'll change it to 7.5 on the medial, 8.5 on the lateral, in a way that you will restore the kinematics. Okay, you try when you start doing kinematic alignment, you have to ignore angles. Okay, angles are not important. It's a pure bony procedure. You don't touch the soft tissue, you don't release MCL in like 99% of cases. Then, also in the tibia, we take the transition zone between the where there is still cartilage and no cartilage at the medial part of the tibia, and we take from there for the beginning, like 3 millimeters difference between the lateral and the medial, and you do the cuts in this way. It's very hard sometimes to expect how the balance and the stability will be after you finish your cuts. So you have to expect sometimes that you will do a recut, especially after removing all osteophytes. After I do the cuts, I still go and do my measurements. Well, I used to do it. Now that I am sure that the vellus is accurate, so I cut, the vellus saw is 2 millimeters. So I look for a 7 millimeters cut on the lateral distal condyle and 5 millimeters cut on the medial. You can accept 0.5 millimeter of difference. Same for tibia. I look that I am symmetrical on the medial and lateral part from the anterior view, taking into consideration the wear on the medial side. Sometimes the wear is much more. If we say that on the femoral side, we can lose up to 2 millimeters of cartilage and there is no bony loss, on the medial side of the tibia, sometimes the bone loss is much more than 3, 4, or 5 millimeters. So you have to take it into consideration. And also for the slope. The photo on the right side shows that I look also on the side view of the resected tibia and see that I have restored the original slope of the patient. Then we do a trial reduction with the implants and start thinking, are we satisfied or not satisfied? Once we have done that, we have this table which was published by Howell, and you balance the knee and get the stability by recutting mostly the tibia or changing the thickness of the poly. So recutting the tibia with the vellus is so easy. You just add, I suggest to, if you change the degrees to 1 degree more varus or valgus, to take also 1 millimeter from the untouched area, so it would be smooth and straight. Because if you change only the angle without changing the thickness, it would have a bump over there. So it's better to take from the high side 1 more millimeter. In this way, you will get like 2 millimeters from the medial side, 1 millimeter from the lateral side, and it will be straight. But this is how you balance the knee. I'll show you an example. This lady, I operated on her right side. So it's a lateral osteoarthritis, a valgus knee. But if you look on the tibia, it's not a 90 degrees. It's a little bit of varus. So after we do the surgery, this is how the X-ray looks. So we have like 1 degrees of varus, 2 degrees of varus here, but you see that the implant covers the bone just the way it's like completing the bone. Okay, look at the posterior condyles, how it's the flare of the femur, it just continues with the posterior condyles of the implant. And when you do the mechanical alignment, you will change that. You will do the external rotation, take 2-3 millimeters out of the healthy bone, like you take less bone from the lateral posterior condyle, which is healthy. So like you take 4 millimeters out of the lateral posterior condyles and 11 millimeters out of the healthy, non-healthy medial condyle. So probably that will change the kinematics of the knee. And I believe that assists the dissatisfaction of some of the patient. The whole functional knee, and it's almost the same as kinematic knee in most of the cases, but it's like a way of doing stuff and saying, I don't want to do kinematic knee, so I will settle for something else. But that's in Professor Howell had, so they, like many surgeons in the state, didn't want to hear from him, and for many years went against him. But nowadays it's being more accepted, and I really feel today that when patients come to me 6 weeks, 4 weeks after surgery, sometimes I forget if these patients are hip or knee patients. This you won't see in the kinematic. I didn't see that in the mechanical alignment, but I see it in the kinematic. So maybe the percentage won't change. The number of revisions won't change, but I think the range of motion will change in the end between the groups. If you do kinematic and if you do it with a robot, you are more accurate in balancing the knee. So the basis is balance. Kinematic can be changed 1 millimeter here, 1 millimeter by like the functional knee, but the numbers that change are the proms. The patient satisfaction will surely change with kinematic alignment. And the same I do it with cementless knee. It's the same thing. I do robot Willis and I do cementless knee, and I don't care if it's a 4 or 5 millimeter degrees of varus. Thank you.
Thank you, Dr. Nabil. I now invite Dr. Swaroop to give the next talk on robotic-assisted mechanical alignment in a CT-based system. Request to all the speakers to be very precise and short because we are running out of time.
More about, apart from the timing, I think what the normal delegates who are not using robotic arm, and many of them do not intend to use robotic arm in near future, would like to hear why you want to use robotic arm. Yeah, so that's, I think, is very valid point. And whatever robotic arm you are using, why you are using that, why not others? These are the things I think they are more interested. I had a talk with them, I went for coffee because many of the delegates were having coffee, and they said, boss, हम तो robotic arm अभी use नहीं करने वाले. So I think this is what will interest them more. And I think a couple of points which we can gather from what Dr. Nabil said is that the joint line restoration becomes very vital, because the moment he said how much you are cutting the bone and how you restore with the implant. So that's very, very valid point, and the stability is very important. So now we all know these are the two crucial things in a joint replacement, especially if we are talking about knee at the moment. So joint line restoration and mechanical stability or a stable joint where the ligaments are balanced well. So these two things are very vital if you can gather from all the concepts. What robotic arm, so we would like to know how robotic arm is helping you to achieve this also.
Should I start, sir? So this is a very good slide. So before we all get into the technology, we need to understand that technology is only good till we are guiding it. It should not become a dangerous master. So image-based or image-less, there may be little confusion, but I prefer image-based system because it is a better way of measuring things, gives better accuracy. Same slides just to point out. Advantages of city-based systems, you can plan it pre-operatively. You don't have to get into the theater and then you have to start planning. And planning as we have been templating in the past, so it has its own advantages. Other things what we get is a component size. How will it look on a CT when we are convinced that this is the position which we want? The amount of bone loss, we already know how much bone loss we are going to get, so we can plan a little better. And for senior surgeons, I think that may not be a big valid point, but for youngsters and starting robotics, that is little helpful. And having the implant positioning, knowing it pre-hand to how the cuts will look and how the implant will be positioned, that is a great advantage. So lot has been said about the kinematic alignment and the mechanical alignment, but I still believe that's the gold standard, and for a newcomer, for me, I think gold standard should be a better choice. Yeah, the question can arise, why robotic then? But I feel robotic gives a little advantage over the cuts which you take, those are more precise. So just a trip. So in mechanical alignment, the flexion extension gap has to be balanced. We all know it's same what we are doing in robotics, is just the arm which is cutting it. Everything remains the same how we have been trained to do a knee replacement. In a varus knee, we try and attempt the good side, that is the lateral side, and in a valgus, we attempt for the medial side. So Professor Arora sir has already shown this, how we mark it, how we see the position, how we see the rotation, how much is the rotation, how the patella is going to fit with the implant, how it's going to track. So we can see how the cut will look. We have removed the implant from this image. So we can put it back. We can see how the cut is going to look. So this image-based systems, for me, I think gives a little more courage and little more helpful. Another point which I feel, you can mark your own points in the tibia and the femur where you are going to correlate with the CT-based image system, which is not available, I think, in the imageless system. So looks little more cooler with the colorful things. So this is what we were attempting. So the whole things remain the same. That see, this is the before putting the incision, the medial side is 5 degree and the lateral is 8. And what the computer or the navigation system was showing, it is 10 in the medial side, what we can achieve, and 11 and 10 on the lateral side. So this much release has to be done because the robotic arm has to go inside, the burst system has to go inside and do the cutting part. One major advantage, you don't have to release the soft tissue, yes, and in clinical practice, I have also noticed that the patients are little more happier in the early days as compared to when we release too much of soft tissue. So this is what we were getting after the release. So 8 and 8, the implant comes with the 9 size, and this is what the navigation system was showing, the robotic system was showing. So this is what we desired. So we have just moved the femur one side up. When I saw the lateral side, it was a very healthy cartilage, so I poked my knife in, so I think it is 2 mm. So taking off 9 was the ideal size, so I just went 1 mm up, so it is 7.3. So now it is showing a very balanced knee, and this is what I want. So the flexion gap is maintained in the medial side. 1 mm or 2 mm, as per the paper says, it is acceptable when we are using navigation or a robotic system. And this is in the 90. So this is the desired. So this is just after placing the component. So your feel is most important no matter what the computer or the robot is showing. So I keep my knees very tight. And I have checked in all positions like 90, is it opening or not? Is it opening in varus, valgus? So this feel is very important no matter what the computer says. So once I have placed the component, so once I was reading a paper, so I got this. So once you have, this is the final placement of the component. This is not the trial, this is the actual, and this is what we are getting. So this is 12. So this is what's the desired one, and this is now what we are getting at 90 degree, and this is what we are getting at full extension. So technology helps, and still I am a strong believer that mechanical alignment is the best and gold standard, and I have been following that. In very, very tough situations, I may resort to kinematic alignment, but I think mechanical alignment is the key and workhorse for me. So these are just few X-rays. Image-based or imageless, no confusion, it is all same. There was a very fantastic study. This has compared head-to-head the image-based and the imageless system, and they came that both the systems have a very different way of measuring things. And they have given many reasonings. The time is short, we cannot go into inside of that, but they have the different points from where they collect the coronal and the sagittal alignment, and so that has little difference, and the way of measuring it is also very different. So that's it from my side. My take home for this, mechanical alignment has been the gold standard, whether we have been using a robotic or a non-robotic. As I said, that knee joint line and everything should be in place. So getting that, whether with the help of a robotic arm or with your own hand, that's the gold standard technique to do it, and I firmly believe in so. Thank you.
Thank you, Dr. Swaroop. May I invite Dr. Rajkumar for the next talk about his experience of using Velis with Attune PS.
Yeah. Before they load the laptop, I would like to thank Dr. Prasad sir and Dr. Anand for this wonderful meeting and the invitation. Thank you, sir. And before I start my talk, I would like to make two important points. One is, the first point, Dr. Rakesh asked whether the robot will make surgeon more better, still more better. Definitely the answer is no. Like, the robot will help the surgeon but not make the surgeon better. If the surgeon, if he is better and skillful, he can do a better job with the robot, help of the robot. So that is the point number one. Point number two, my talk is not going to be based on, not based on whether kinematic alignment is better or mechanical. It is a big debate. You can talk the whole day, which is better, constitutional, functional, all those things. My talk is purely on how imageless robot system helps and what is the early assessment what I have done. So, without wasting time, early assessment of total knee done by imageless robotic Velis system. I use Velis. All these cases are PS knees. So in India, the prediction is big. Particularly in India, by 2030, 35. Yesterday, also in the faculty dinner, we were talking about the huge volume of knee replacement surgery is going to go up. But whatever certain said, the problem is malalignment, bone cutting inaccuracies are the major issues. Whether we are a very big, great surgeon, when we do it mechanically, definitely there are some chances of errors happening. So we have to accept that, because we all see in the high volume centers, we can see that the more mechanical, more manually done TKRs, even though they claim that the accuracy is perfect, but if you measure it, there are bone cutting inaccuracies can happen, and malalignment are the major problems in conventional total knee. So to bridge that gap, the advantage of robot is big. So that is the most important. So many systems are here, image-based, imageless. A lot of, all the previous speakers, they spoke very high about each system. So what I use is the Velis, the robotic imageless system, and I'm not going to go in detail. So the aim of this study was to determine the early clinical outcomes. At the end, I'm going to say definitely the assessment early clinical outcome is better. That is what I'm going to say, because it is definitely the result was good, but we just wanted to see whether both ways, non-robotic and robotic, is there any difference? That was what we want to see, and I did around 60 cases in 2 months' time, and I studied those cases, and all the patients were admitted 1 day prior, and then all the routine x-rays done. Since it is an imageless system, no extra CT or any other x-rays was done. Routine cases, what we do for a manually, we did all the same x-rays, and this is how the setup is. Not going to go in detail. So Hemant was asking about all the removal of osteophytes and meniscus. So my pathway is, I open it as I do for a manual, remove all the osteophytes. I don't do any release. I remove all the osteophytes, all the meniscus. I remove the ACL. I remove the meniscus. So I am ready to go, even without a robot, I am ready to go with a jig. So in that situation, I go and put my pins in the tibia and in the femur, and then I do the registration. And after the registration, before taking the tibial cut, I do the flexion extension, and there is a graph which shows how much of flexion is there, how much of extension I am able to, whether there is an hyperextension, whereas the flexion deformity is there. All those assessment is done, and once that assessment is done, then the pathway is either femur first or tibia first. I go with the tibia first. So this is the pathway. So I'm not going to go in detail technical. So this is the initial assessment, and then how much of correction it is happening. So remember, I have done all the osteophyte removal, meniscus, everything. So this is the graph it shows, and here I plan it. I plan that, and then I do the tibial cut, and after the tibial cut, I use the tensioner. So this tensioner, as it was discussed in detail about that the small and big is there, it gives me a real-time feel how much of opening is there on the lateral side and what kind of stability I need to achieve. So the moment after the tibial cut, I put the tensioner, I do the adjustment in the femur, and that helps me to match the graph, and then I go ahead and do the distal femur, spacer, and then the tensioner, and then the chamfer cuts. So the post-op protocol, same. What I do it for the manual. Post-op analgesia is standardized, no use of opioids, active knee bending, and adductor canal block. So the results were like patient had a better outcome in the early post-operative period, good range of motion, no pin site complication, no superficial or acute infection. So this is a busy slide where it shows about the result, and you can see that all the VAS score, the improvement is good in the first few weeks, immediate post-op, 2 weeks and 3 months. But the big difference was in the immediate post-op, where somebody mentioned the patient, Hemant was mentioning, patient was little, manually if you do, they are little reluctant, always telling here pain, here tightness. But in these cases I found out the patient recovery is faster in the immediate post-operative period. We might be little biased, but there is obvious evidence is there. That is how I found that in these 60 cases. Definitely it helps. Excellent functional outcome with better overall patient scores. Clinical, non-clinical. Key advantage of this system. Again, the Wellness system, it's surgeon control, saw-based, but it is imageless. So no increase in time. And the literature also. This is a few cases, pre-operative, and you do the planning per-operative. This is the post-operative X-ray. And the difference here is the immediate post-operative. Immediately. So the patient is able to do all these things. We can show many videos like that, but definitely the patient is telling that there is not much of pain, so they are able to do that. Single stage bilateral. Again, patient walking next day like that. Patient was happy to walk without much pain, and the movement is also good. Whether the same thing we can argue that we can achieve in non-robotic also, but definitely this helps. That is the whole point here. This is the post-operative. The big advantage here is this kind of systems. Like you might need a navigation, but with this robot, with the implant in situ, 73-year-old female, we don't need to remove this. No need of 2 procedures. Just with the robot, you can go ahead and do it without much of issues with the perioperative removal of nails, blood loss, all those things. Patient is walking. So here is the big advantage with this system. I will say, leave about all the alignment part. Accuracy in both cuts is the best part of this system. It is so good. And this is the one which I said about the tensioner. After taking the tibia cut, you put the tensioner, it helps you to assess how much of opening is there. And because remember, by this time we have already removed the osteophytes and everything. Now you know whether you need to do anything more. Most of the time, 99% of the time, you don't need to do any release because you have removed all the osteophytes. You just need to do the planning. Do the planning. Based on that, you rotate the femur, shift up, down, lateral, whatever you want to do, achieve the graft, and then get your implant in. So the big advantage here is the Vellis is it's a smaller footprint, single page planning, imageless, accurate and precise bone cuts. Thank you.